Opportunity. If I could talk something about genetic counseling to this particular specialty, where all of you have advanced so much in technology that it is possible for you to probably help people who are having hearing impairment to best of your ability and the technology's ability. But unfortunately not been able to give them accurate counseling just because the modes of inheritance or the type of genetic disorders which are associated with this are not you are not well acquainted with it. However, I think that I am proved wrong because I saw Dr. Waghela giving beautiful presentation on syndrome, and I am surprised that I think all of you know all these syndromes. May I ask this? Yes or no? 50-50. Okay, fine. So I think that we are those who do not know have learnt about it, and probably the transmission, the pattern of transmission, which is important, which I am going to explain about that because not discuss the syndromes and what usually as a genetic counselor we face, because we see all the patients whenever they are having pregnancy, like a woman will come, she is pregnant and then she will give history, okay, in my family such and such family member is affected, or I have a previous child with a problem. So probably every specialty when I speak to, I always tell them that you are the first ones to pick up the high risk cases. Don't just stop at evaluating that case and giving treatment to that, but consider that child as a family where you are going to give information to the family how to prevent it further. So probably that time they require genetic counseling to be given. When I was invited, I don't know why one picture has disappeared, it was, yeah, okay. When I was invited, I first thanked Almighty that thank God I can have both these functions, and couldn't forget remembering his master's voice. Probably I heard his master's voice all the time to do something in the field of genetics. So that, and of course Graham Bell, because I love to chat on phone. Now when we talk about deafness, we know that it is a common and distressing disorder due to environmental and genetic causes. Incidence being 1 in 1,000, and you can see we see maybe one case in 3 or 4 months who come for genetic counseling. So in spite of incidence being so high, genetic counseling is very poorly offered to these patients. And then of course half of this being of genetic origin, because usually when first child is affected, then they just want to know what is the chance that my second child will be affected, or if any other family member is affected, what is the chance that we can do prenatal diagnosis, is there any way we can prevent it. And then when we talk about prevention, we have to look at the epidemiology and etiology, again which is again covered by Dr. Waghela. But when we take history, we look into all the factors, and again the same is not possible for a busy practice in your specialty. So environmental and acquired causes, hereditary causes which are syndromal and non-syndromal, and unknown. Naturally, parents' concern is why our child, what is the chance of other child having it, and if both of us or one of us is affected, what can happen. So what do we do in genetic counseling? What is the purpose or what is the aim? So what is the process? It's a process of communication and education. It explains medical diagnosis and prognosis. Medical diagnosis, we tell them you have to come with all your reports, because diagnosis is the one which you are going to make, we cannot make because we are not experts in that. We may have some idea about genetic syndromes, but accurate diagnosis is very important. So diagnosis and prognosis, discuss the mode of inheritance, that is very important. Choices or options of dealing with the risks, recurrence risk estimation, prenatal diagnosis and prevention, possible reproductive options, support group and follow-up. Now when we talk, we all know that our genetic material is packed in each cell of our body, and it is in the form of chromosomes, and if you stretch the chromosomes, which are actually coiled or packed DNA material, and anything going wrong in the form of chromosomes or in the form a single base pair missing, the result is disastrous. Common prenatal and environmental influences, as you can see here. Now the other amniotic fluid bands are for other birth defects. So whenever we see a child with a birth defect and hearing deficiency, we want to make sure that whether it is environmental or the birth defects is because of some other, because when they come to us, they don't come only for hearing deficiency if it is associated with other birth defect, and they would also like to see if the other birth defects can be prevented. So we also, in spite of knowing that it is associated with hearing deficiency, We look at the other physical factors as mentioned here, chemicals, if anything is consumed during pregnancy like drugs, infections and also radiation. Now congenital infection rubella, again we have seen beautiful slides, and with the introduction of MMR vaccine, I think overall death rate due to rubella is decreasing. Also it is possible having good neonatal care, good antenatal care or good perinatal care. Prematurity and dealing with jaundice, neonatal jaundice also is taken care of. Postnatal infections, again mumps, meningitis, measles, these are also well taken care of. So what remains is, if the environmental factors are controlled, to look more into the hereditary causes, that is syndromal and non-syndromal. Again we have seen this slide in Dr. Vagela's presentation, and we know that 70% are non-syndromic, 30% are syndromic, 1 to 2% are X-linked, of which 20 are autosomal dominant and 80% are recessive. When we talk about recessive disorder means both the partners are carriers but not affected, and it comes as a surprise to them when a child is born with a hearing deficiency or any genetic disorder of recessive origin, and they would definitely want to know why this has happened. So that takes care of the recessive. I think syndromes we can, since we have already done it in details, I can just skip the slides of syndromic hearing loss, just to mention that when we examine a patient for genetic counseling, we will go through all the syndromes, find out how best it can be evaluated, because most of the times we get inquiries on phone call. I have such and such patient with this history and there are these symptoms. We would say no, we would like to have the full file to review, because very few genetic centers are available. Many a times the consultation is sought on telephone. So unless we have got the details of syndromology or evaluation by dysmorphologists done, we will not say what would be the recurrence risk, because they would take a blind chance and they might land up with some other problem. Also, importance of identifying the syndrome is, we may have various prenatal diagnostic tests, which I am going to just mention later, by which we can diagnose the syndrome if it is associated. For example, if the hearing loss is associated with chromosomal syndromes, then we have a method to estimate recurrence risk by doing various prenatal diagnostic tests and see that this particular pregnancy or the child is healthy. Again, I would like to stress that please don't forget that try to evaluate the child and tell them to seek genetic counseling, or if you can offer them before a woman is pregnant again, because then whole focus is on the affected child and most of the valuable time which we could have otherwise given for pinpointing the cause is lost. So we have seen about Usher syndrome, Waardenburg-Treacher-Collins syndrome. We had a case of Treacher-Collins syndrome where till the first child is born, nobody noticed that the father was also a Treacher-Collins syndrome. Mild hearing deficiency, typical phases of Treacher-Collins syndrome, craniofacial anomalies, and because of just keeping his neck slightly twisted, and then we didn't know how to tell the wife. Genetic counseling is very tricky. If you say that husband is a carrier or husband is affected, okay, it can be pardoned. But if wife is a carrier or affected, he is ready for second marriage. So we have to always be very careful when we are doing genetic counseling. We have to ask with whom are they coming, who is accompanying this person. So first thing which is asked is, who are your relatives who are coming with you, and accordingly we have to just play our cards. Literally it is playing cards when we are doing genetic counseling. So then the second pregnancy, when she came, when nobody was evaluated, we knew clinically looking at the affected child was diagnosed, but father was never diagnosed, and it was a clear-cut autosomal dominant inheritance, and we knew that there was a 50% chance of second child being affected. Then of course the other syndrome she has already mentioned, so we will just skip acquired syndrome, neurofibromatosis. Then why this hearing deficiency occurs, or why we cannot for sure tell. Even if somebody comes for genetic counseling and tell me precise risk, I am ready to spend crores of rupees to find out whether my second child will be affected. It is not possible, but we can come to the closest, because diverse genes are responsible for operation of auditory system that we are aware of. Now look at these responsible, and how many genes so far have been identified responsible for a hearing deficiency. Now when we talk about hearing deficiency, it is not only one particular chromosome which is responsible. Things would have been much easier. Like I said, that in syndromic hearing loss, we can just say, okay, previous child with Down syndrome or previous child with Edwards syndrome having hearing deficiency, we have a definite prenatal diagnostic test. So we just show this chart to the patient and tell them that it is possible for us to tell you, not to tell you up to 100% certainty, because so many genes are responsible to control one function. In common locations of the sex chromosome, that is what I have shown, because here what happens, if there is if our evaluation says that there is a sex chromosomal, it is linked to sex chromosome, then prenatal diagnosis for sex chromosomal abnormalities is permitted, where we can disclose the sex of the fetus and then give them the risk. But again, whether to do prenatal diagnosis in these cases or not, I will come to that at the end. So just see number of genes responsible for producing various diseases which are just related to sex chromosome. Now when we talk about sex chromosomal, that means the males are affected and females are carriers. But sometimes if females have structural chromosomal abnormality of the X, second X or whichever X, then chances that female also will be affected is higher. So in all the cases, even if it is your syndromic, non-syndromic hearing loss, we always do chromosomal analysis, because any abnormality in structure of the chromosome, number of the chromosome will definitely give us the syndrome, but structure of the chromosome can lead to hearing deficiency. Now the classification also has been told by us. So when we evaluate the case, this is not actually non-syndromal, it should be categories of genetic diseases when we talk about. This is any of the chromosomes in number and structure being altered is the chromosomal syndrome. Single gene we have seen already, and we also have another group called as mitochondrial, where again it is transmitted by a female, because ooplasm contains mitochondria which are transmitted to the child. We all know, and the sperm head not having cytoplasm, it is not transmitted by male. But males and females are both affected, though it is transmitted by a female. Now this particular thing occurs because of the recombination which takes place at the time of meiosis, and we should wonder how we are born normal. So number of permutations and combinations which are going on during the process of meiosis or during the process of segregation of the chromosomes, many abnormalities can occur. Now characteristics of autosomal dominant is, we can just see the transmission, because it is essential to know this again, like for 50% of those who said they are not much aware of the genetics, I think it is for their benefit and it is for the others to revise. You can see that if we draw a pedigree, that is a must, I think that we should know. Taking family history also becomes very important for minimum 3 generations. If you find the transmission is vertical, that probably each generation, one person is affected. If each generation you find a person is affected, you know it for sure that it is autosomal dominant inheritance. Now if it is autosomal dominant, sometimes you will find in this inheritance pattern also, you will find that yes, you can see out of 4 generations, 1 generation it is missing, and then you feel that it has disappeared. Because autosomal dominant inheritance gets variability of expressivity. So probably the penetrance is not there, so it might have missed, that penetrance will be low, and therefore it is not possible for you to see in a classical hearing deficiency form or a person being affected. So we always evaluate or have audiometry requested for the parents, even if you don't see. Then only, because maybe that one child is affected, one of them is a carrier, and we will totally miss it because of this dominant character having low penetrance. So audiometry for the parents also we always ask for. Now then coming to the autosomal recessive inheritance, as I told you that both the partners are not affected, and you will find that because every individual has got 48 abnormal genes, and it is a matter of chance that 2 persons carrying that abnormal gene marry, and then the risk is 25%. So if one child is affected, then the risk becomes 25% for any genetic disorder. It definitely increases with consanguinity. So again, taking history of taking family history, finding out what degree of consanguinity they have. That is very important when you are taking this kind of drawing this kind of pedigree. So you can see two horizontal lines represent that there is a consanguineous marriage, and naturally the percentage of or a community where the consanguineous marriage is a practice or a common practice, the incidence of any recessive disorder, not necessarily hearing deficiency, is increased. And then of course we counsel them and tell them, they will immediately tell you, so what, so many people in our community marry. But we have to tell them that since you have this history, henceforth see that in your generations to come or your other blood relatives, see that they do not go in for consanguineous marriage. So you will find that there is a horizontal transmission, male and female are equally affected in both this vertical as well as horizontal transmission. I told you in sex-linked inheritance you will find that there is a dominant other genetic disorder in dominant trait. It is actually the pregnancy either is non-viable, it is that severe, so you see hardly X-linked dominant, but yes, in some hearing deficiency you may be able to give. But sex-linked recessive inheritance is the common, where you can see that circle with a dot represents a carrier status, where a known carrier status is there, and you find only the males are affected. I told you it is possible to offer them prenatal diagnosis. Then of course we have the human being. We know that it is a masterpiece of engineering. I showed you how many genes are controlling the mechanism because of the I think the most intricate organ of the body. So you may have in a certain type of disorders which are called as polygenic disorders, where there is familial clustering, but they do not follow a definite Mendelian pattern. So certain traits in the family also follow the same thing. And in multifactorial there is history of genetic and genes and environment. Again, when family history is taken or obstetric history of a woman who is presenting with a child with hearing deficiency is very important, because probably she may have genetic as well as environmental, both the factors. So taking drugs in pregnancy, illness, infections, that history in addition to that, even if there is a classical syndrome, is very important to take. We have seen about non-syndromic hearing loss, and recent developments have identified 70 genes which are known to be having non-syndromic hearing loss. And the common mutation which is seen, actually it is seen very much common in Caucasian, but it is connexin 26 gene which is responsible for 30 to 50% of the non-syndromal hearing loss. This mutation is easier to study by doing molecular test, and again I will tell you why it is not being done routinely. Now this is connexin 26 is highly expressed in mammalian cochlea, and therefore mutations are more likely. More expressed it is, more chances that recombination will take place, and more chances that you will have a risk of connexin 26 being mutation being present in that. Incidence always shows a regional variation, like in Maharashtra, like 15.4% in Maharashtra to 36% in Kerala, and I have told you that consanguinity increases the incidence. This of course you know more than me. Now this connexin gene was first identified for autosomal, because it is located on autosomal hearing, the gene responsible for autosomal type of hearing loss. And these proteins are responsible for this intra, as it is mentioned here, that they lie in the intracellular channels or gap junctions, and that connect adjacent cell and facilitate exchange of ions secondary to messengers and small molecules. Geneticist, I don't go into complexity of how it is being done, but I want to know how a test is done. The test is very simple. If one couple comes and you have identified, ruled out all other causes, then you say, okay, could be that I want to test this particular couple for connexin 26 test. So this is done on a saliva or blood. Reports may take from 8 days to 1 month to 2 months, because depending on the sequencing. One very tricky thing about genetic disorders is some genetic disorders, to give a diagnosis, for example in retinitis pigmentosa, to suppose if a person comes to you with retinitis pigmentosa and wants to know his chances of transmitting to the progeny, to evaluate that person we may take 6 months. So if he comes when his woman is already pregnant, that means we cannot offer prenatal diagnosis in that pregnancy. And therefore again and again I stress upon that try to evaluate the cause, try to have a proper counseling done, so that the next child or the family is benefited. Similarly, tuberous sclerosis, we take 1 year to identify the mutation in the affected, and unless mutation in the affected, we cannot offer prenatal. 1 year to identify the mutation in the affected, And unless mutation in the affected is identified, we cannot offer prenatal diagnosis or cannot even give recurrence risk. Then of course we can just skip this slide. What is the evaluation method? Is taking family history, maternal and obstetric, pedigree charting, audiometry for type and severity. We ask for reports, though we don't understand how to read it, but we'll see what have you written below. Then physical examination for associated abnormality. It's a fact, you know, when patients will come with CT scan to us, to geneticists, because we see patients from all these specialties. So neurologists feel that we should be expert in that field. Or whatever, can I get?
Yeah, can
continue. Okay. So you know what happens? I don't want to just pretend that yes, I am expert and I am just looking at it. Actually, I don't understand. I said, please give me title. Because that is what is very important for me to, I am not there to act, but I am going to there to deliver goods. So I would depend on what you give me and I will trust your expertise in that. Then of course, physical examination for associated abnormalities and specific and specialist examination. Genetics and genetic counseling is again you can say multi-speciality effort, because we require input from all these specialties. Now of course neuro-otological assessment, pure tone audiometry, auto admittance test, vestibular evaluation for proband parents and siblings. If somebody is not complaining of hearing deficiency, he says okay, I can hear, because you again you can tell, but probably I mean nobody will accept कि हाँ इतना कम सुनने का था, ठीक है ठंडी में थोड़ा कम सुनने का, whatever it is, but you have to get them evaluated for us to give them accurate genetic counseling. For syndromes, like you have to look at the external, we have to rather look at the external ear anomalies, pigmentary anomalies, posterior clever, because all these syndromes are associated with some kind of external malformation. Now goiter, Pendant syndrome, thyroid function and perchlorate test. Now there is one small pocket near Ratnagiri where surrounding that small island, I have gone there personally and I have seen in every family there are 2 or 3 children with thyroid deficiency or individuals, and they were diagnosed. If I can get the details, maybe because of this interest in your field or your interest in my field, I can just forward that information, and if somebody wants to do a work on it, it will be valuable, because every family, and they take it that okay, everybody has goiter and 1 or 2 members will have a hearing deficiency, and again there is too much consanguinity in that community. If somebody, Dr. Ime wants to, or Dr. Kirtane wants to do a project, I think it is worth looking into it. Then of course the other tests including chromosome analysis we have to do. Physical examination, we have heard about the importance of doing electrocardiogram and prenatal diagnosis, because fetal echocardiography is now possible. So you can just do this Jervell-Lange-Nielsen syndrome. If there is a history, you can offer prenatal diagnosis by offering fetal echocardiography for recurrence risk estimation. Then chances of recurrence in various meetings, the questions will be always hearing into hearing, deaf into hearing, deaf into deaf. We cannot answer anything unless we have got complete evaluation available, and that too in proper syndromes, identified syndromes, definite risk can be offered, but certain cases we would say that your risk is higher or lower. This is what journal of course
result outcome
sibling is affected,
study
then this is 1:10, offspring, then 1:16. So I think you can just go through this chart. Probably every book gives that. What is important is why there is a need for an expert opinion, because there are various tests available. Is it a metabolic syndrome? Is it a chromosomal syndrome? Which test am I going to offer this patient? If you say that you have to do tests worth 50,000-60,000 rupees to come to a conclusion, what will be the type of inheritance? They are not going to accept it, and you might miss it, or they might have another child with hearing deficiency. So it's very important to have that, and again being interdisciplinary, we also depend on the reports from various systems. So probably a geneticist can give this answer. Now in prenatal diagnosis, today Now whenever you are doing prenatal diagnosis, are chorionicular sampling, which is done between 10 to 11 weeks of pregnancy, and of course amniocentesis at 15 to 17. Both the procedures have risk of miscarriage, but it is 0.5 to 1% in case of amniocentesis and 1 to 2% in this. But if the disorder is associated with chromosomal syndrome, which is associated with mental retardation, then definitely termination of pregnancy is allowed or can be offered. So these procedures we are still using definitely for other abnormalities, but if it is if the deficiency is associated with it. So in conclusion, genetic counseling in hearing impairment depends on family history, audiometry, physical examinations, specific investigations and specialist examinations. So if we are fed with all this information or we can do some of the tests, then we are able to offer genetic counseling. Now it comes to that if we can have one Helen Keller who was having deficiency and in spite that she could become a superwoman. This is the objection taken by hearing people who are having hearing deficiency. Though prenatal diagnosis for connexin 26 gene is available, if we can also are capable of becoming Helen Keller, do you think that we should be terminated? Thank you very much.
Thank you for the wonderful presentation, ma'am.